Hello, welcome all to another Wednesday night. Of course, Wednesday night means KFP time. My name is Kane Treble. I'm a GP Reg up in Mildura. Hopefully you have had a great week. I've had a busy week. I imagine most of you out there in the final throes of study before planning to sit. We are, of course... Knew that wasn't going to work tonight. We are, of course, if that wants to work, and there we are. 3 days. 3 days from the 2024.1 KFP exam, and I'm having all kinds of issues tonight. Let's get this audio patched. Hopefully that is working better for you guys. Now, the final throws, we are in the last lap, so to speak. So I want you to be asking as many questions as you can think of, as many questions as you want answers to, because this may be the last chance before you sit to get those questions out there and get some answers back. I might not have all the answers, but I'm certainly going to give it a shot to give you the best chance possible of getting through this exam. Now, of course, I did promise we'd go through some of the things that might come up in the exam. Of course, no one knows for sure except for the college, but we do know that there are common themes that tend to come up again and again. So I've put together a list here of what are the things that I've noticed come up multiple times through not only the exam questions but practice exam questions. What are the things we're likely going to see? You're almost always guaranteed to get some kind of abnormal uterine bleeding, just one of those things that they're going to want to assess and know that you know something about. We spent a fair bit of time on Aboriginal and Torres Strait Islander health last week. We're going to go through a little bit of ethics and policy making, skin cancers, dermatology, ECG findings, mental health, emergency cases, your DRS ABCD, paediatrics, they're more than just little people, immunisations. I've said it so many times, I'm so sorry. As well as cough, shortness of breath, CCF, malignancy, and touch again on radiology. All right, let's kick off then with the first one here. For those that aren't familiar or don't have kind of backup mnemonic in place, palm cone is the one that I think is most helpful for people that may not be as familiar with abnormal uterine bleeding. Maybe you're a male in a practice that you don't see many female patients. This is something you should know. It's essentially a little mnemonic to try and get you to remember what are the structural, palm, and non-structural causes, cone. So most people can think of polyps, very, very common cause, adenomyosis, leiomyoma, which is the fancy name for fibroids, and of course malignancy, the one that we're going to be very, very mindful of. Non-structural causes could be coagulopathy, ovulatory causes, endometrial dysfunction, iatrogenic, so things like the Mirena or Implanon, for example, and of course the other not otherwise classified group. If this is something that you don't feel comfortable on, I would strongly encourage you to just read quickly through a brief update through each of these kind of topics and just become vaguely familiar with what are the things you're going to need to know. Really, that's going to be what is going to be most important to know for different age groups, different presentations, and to know as well a few questions that you can throw at Oh boy, sorry guys. I want you to be able to throw out a few questions on ways to differentiate each of these conditions. I want you to be familiar with what the most recent guidelines are. There's some stuff that you'll find up on RACGP, other things that might come up tonight, topical, like a cream. And I want you to know probably the most important of all these things here is what are going to be the most appropriate first-line investigations. Often for these kinds of things, we don't necessarily get asked the second or tertiary investigations. What our job in general practice and primary care is often to do the screening to work out what are we dealing with and who do we need to get them engaged with for a lot of these issues, at least. Now, as I said, I don't want to go too much into Aboriginal and Torres Strait Islander inequity in healthcare. An incredibly common question or area to be explored in exams. I would strongly encourage you, if you haven't already, have a flick through last week's session. In particular, have a look at the teaching we did on the live stream as well as those individual cases that were put up. So if you're not familiar already and want to do some last minute cramming, there is a playlist on this channel that goes through each of the questions that I've done since I've started this whole thing. Now, ethics and policy making it's frustrating because it's one of those things that I don't think is actually often taught in a lot of the programs, or at least there's not enough emphasis or focus put on it, and it is completely fair game in the actual exam itself. Have a think about what is your kind of structured fallback to handling an ethical dilemma. Who are the stakeholders? Who are the approachable, reportable bodies that you should be escalating to? What is a local policy regarding this? What is a wider area policy? What is a state or nation-based policy that you should be referencing? If you're looking for a bit of a framework to kind of build from, if this isn't something you've had a lot of exposure to, admittedly, I don't think many registrars have probably had much experience in policy making for practices. The address I put up on here, and I will put into the show notes later on as well, actually goes into different blank templates that you can build up for your practice, but it's also a fantastic resource to have a look at and get that prompt, for lack of a better term, of what are the things they're actually looking for when you're putting together policies. What are the things they're going to be assessing for? Now, skin cancer and dermatology. One of the things that I think mucks up a lot of people and people lose marks on is just know the relevant margins for lesion excisions. And if you haven't already, have a good read-through of the DermNet image library. Read-through, it's the wrong term. Look, glance. Flashcards. Most of the questions that you'll get for the exam for dermatology... Oh, I'm leaking from everything tonight. Sorry, guys. Sometimes life just throws you curveballs. Life just likes to knock you down and say, stay. But we will not. We will rise, we will continue, we will push on, and as they say, the show must go on. DermNet have a little image library that you can actually just click onto and scroll through different images. And if you can't look at some of those things and quickly say, oh, I reckon that's this, or oh, I think I know what's going on here, click through and it'll bring up that condition and a bit of a spiel about that. That is by far, particularly given we only have a very limited time left, the easiest way to get very good at the dermatology questions. And surprise, surprise, some of those images might look very familiar in the exams. There's not many massive databases of readily accessible dermatology cases to pull from. And so, of course, the college is going to be pulling from DermNet. So if you want that little bit of potentially an advantage to have that kind of sneak peek of what material could be used, fantastic and underutilised resource. Also, very important to, because they're going to cover multiple domains by looking at rashes and paediatrics, just be familiar with what are the common childhood rashes, how would you differentiate between them for history and clinical examination, and what is a basic approach to each. It's either watch and wait, topical steroids, emollients, or antifungals. That tends to be the rough rule of thumb. Maybe biopsy, less so on kids. All right, ECG findings. I love ECGs. I don't know, something about them I just nerd out over. I worked in ED for a long period of time, and I guess maybe that's put a bit of a love in there for me. This is a consultant level exam, but they also acknowledge that the quality of the images may not be fantastic. Very difficult to kind of be able to print these things on scale. And so they're not going to try and trip you up. They're not going to try and give you something overly difficult. Be very comfortable in identifying atrial fibrillation, atrial flutter, heart blocks. In particular, I'd say third degree heart blocks is a good one to know off the back of your hand. It is one that's, for better or worse, is actually disturbingly easy to miss if you're not specifically looking for it. It goes back to make sure you've got that structured approach to ECG interpretation. You know, look at your P waves, look at your QRS, look at your intervals, look at the relationship between the P and the QRS. And I think if you're doing that basic kind of count, that basic look, you're going to be just fine. Of course, you're going to want to know how to identify a STEMI. Bonus points if you can localise the STEMI, but if in doubt, feel free to just specify that it is a ST elevation myocardial infarction. You'll get marks there. Acute, extra marks. And again, if you add that localisation, extra marks again. And another area that seems to pop up again and again, and everything I'm covering here, I'm not giving away any secrets. A lot of this is pulled from exam reports as well. Just covering my own backside with that one there as well. Adverse drug effects. We're often informed to monitor for ECG changes, and surprise, surprise, that's examinable content. So if you do come across a question that you're looking at an ECG and you're thinking, that looks really weird, I have no idea what's going on, but I know there's something abnormal, and there is maybe an emphasis or a particular placement of a medication in there that you know potentially has those ECG effects, feel free to take that punt and say toxicity due to or ECG changes consistent with. Mental health. Something that I think is a GP's absolute bread and butter. We do this every day, day in, day out, which actually sometimes makes it tricky because we can see a patient, look at the facts and instantly say, okay, I know what's going on here. Sometimes we might be a little bit more forgetful to have a look at specific diagnostic criteria. And something that frequently comes up on these timelines is actually looking at the timelines involved to meet specific diagnoses. That will often come up in the form of either a patient presents with symptoms for a period of time, what is a diagnosis, and that time frame may change the specific diagnosis, or it could be the other way around of what further questions would you have where you have to ask, are your symptoms over X duration to meet certain criteria. Likewise, it's going to be the salient positive findings for a diagnosis and the salient negative findings. Remember, for all these mental health diagnosis criteria, easy marks, if you get stuck for nothing else, is going to be that diagnosis that is not consistent with any other diagnosis or due to substances to throw away there. And they want you to also have a feel for what are the risk factors for common conditions, your depression, your anxiety, bipolar disorder, those kinds of things. I'm going to duck back for a second because, as Demira's popped up on here, your QT intervals and hyperkalemia, yeah, it's always going to come up. So, again, very good things to know. Thanks very much for that. All right, moving on then. Emergency cases. Your DRS ABCD. That's a mnemonic that I still use to this day and has saved my butt countless times. I think everyone should keep this one in their back pocket. If you're ever caught in a situation where you feel like you're experiencing anal flutter, DRS ABCD, check for dangers, check for response, send for help, airway, breathing, circulation, defibrillation or disability. Chef kiss. It's going to do you until help arrives or you get that flash of inspiration that lets you know what direction you should be heading in. Now, something that the college also loves is adrenaline. The first line management for anaphylaxis is adrenaline. The second line management for anaphylaxis is adrenaline. The third line management, good marks to know adrenaline. It's one of the few times you may actually be asked for dosing, knowing that 0.5 is your appropriate dose for IM adrenaline in anaphylaxis has been a question. In a lot of the study material that I've gone through, and I think would be a very fair game thing that we should know off the back of our heads. You should also remember that ask for help component, and an easy thing to remember is often they'll specify you're working in a rural setting, and so often that means actually sending them to St. Elsewhere's, organising that transfer to a higher acuity care. This is examinations based at general practice, acknowledging that many people are going to work in urban centres and may never work in ED, but they want to prepare you in case you're locuming in a rural location where you may be the only doctor in that entire town or region. You need to know how to respond to an emergency situation. And tied into that as well, something that we often forget, or it may just be that something we would do without even thinking about it, for management of emergencies, often IV cannulation is worth an easy mark. And of course, don't forget for all emergencies, there's going to be that continuous ongoing monitoring to assess for changes. Again, nice easy mark if you can't think of other things there. Okay, coming up to paediatrics. There's often a bit of a focus, again going through all the exam reports, on common ENT or respiratory conditions. And if you're unaware or haven't checked, be aware that there were changes to the management of otitis in general practice setting for Indigenous children, taking into account the fact that a lot of Indigenous children do live in urban settings that they don't have the other risk factors that more rural or remote communities may have, and so non-antibiotic management may actually be more appropriate in that setting. So again, if you're not familiar with that, I'd go through those guidelines and just re-familiarise yourself quickly. It should only take 5 minutes. As we said before, know those common paediatric rashes because it's an easy way for them to assess multiple domains in one go by throwing out a rash in a child, have a good idea of what those early childhood rashes could be, and immunisations. Yeah, sorry. As I've said from day one, it's just one of those things you really just have to kind of go and memorise, for lack of a better term. You've got your COVID immunisations, your influenza immunisations to kind of fall back to if you really get stuck, but you really should have a decent working knowledge of what the immunisation schedule is. Again, just going to duck back for a second. To me, you've popped in here milestones. Yes, you will find in a lot of situations milestones can be one of those things that does get assessed. It's often only worth kind of 1 mark. I would be surprised if they have what are the milestones for this age. It's normally are they meeting milestones for this age. But yeah, definitely you should have a ballpark idea. I think some of us are lucky in that we have children in these age groups. If not, try and think back to when your children were in those age groups. And if you don't have children, sleep must be amazing. But it's probably worth just having a quick flick through what are the milestones for different age groups. All right, something very dear to my heart at the moment. Investigations and management of cough, shortness of breath, congestive cardiac disease or lung malignancy. You will often have that undifferentiated cough or investigation and try and have a bit of a structured approach or fallback kind of idea of how you approach these things. Know your first line and second line investigations for each of these conditions and when each might be more appropriate than others. And please read the qualifier. So most common is going to be your simple diagnoses, the common cold, for example. Most important is going to be your malignancy type diagnoses. First line is going to be your plain X-ray, not your CT, high resolution CT chest. Those little qualifiers can make all the difference in the world, so try not to fall for those little traps. Try and pick up on those early, and it'll do you a world of good. Radiology. Now, there can be radiology questions being asked, and often, I think it's actually probably easier questions than what other image-based questions could be. Again, try and think back to your med school days. Really go back to some of those fundamental basics, checking the patient name, checking the patient age or details there, checking the date of the scan. I will put my hand up and say I once was guilty of misdiagnosing a case because I looked at an X-ray, made a call off what I saw, didn't realise that the X-ray I was looking at was the correct patient, but was taken on the exact same date 1 year prior to the day, and I was looking at thinking this was today's X-ray, and I had not realised they hadn't uploaded the newest X-ray. I just saw the day and the month, always check the year, and that was something I'll never live down. No harm came to the patient or anything like that. I just looked like a massive idiot. Now, something that does come up again and again and again is just know some of your common findings for common things. And one of the easy things is know your findings for osteoarthritis and rheumatoid arthritis and how to differentiate between the two. It's going to be those non-uniform joint space loss, osteophyte formation, cyst formation, subchondral sclerosis, or marginal erosion, soft tissue swelling, symmetry, osteopenia or porosis for your rheumatoid arthritis. For all these pictures, similar to the ECGs, they're unlikely to be of great quality, which can actually work in your favour. You're probably not going to get those subtle findings. You're going to get those big shout out loud kind of diagnoses. It's not going to be a subtle possible fracture. That bone's going to be obliterated. And so as long as you don't spend too much time kind of staring at the fine details on the print, I think you should be just fine. All right. Finally, I want to talk about the final 10 minutes. I'd say 10 minutes. It could be 15, could be 20. Set a space of time at the end of the exam that you feel comfortable with, that you think you can realistically achieve, and have a plan for how you're going to use that time. I think that for people that leave early in the KFP, if that's your thing, you don't want to be sitting there second guessing yourself, that's fine. You know, that do you. But I think you have a valuable opportunity to read through your answers and do that bit of screening. Again, I don't think it's your knowledge, your clinical knowledge, that sets most people back in this exam. It's the exam technique. It's the losing the marks from overcoding that mucks most people up. Number one, check the number of answers for each question. Make sure that matches the requested number. If you have not given enough answers, you're missing out on marks that you can add an answer to it. If you've answered too many questions, you're going to miss out on marks. You're going to lose that 0.25% of the overall score. And I know it doesn't sound much, but geez, does it add up quickly? That's going to be that element of overcoding. Likewise, have a read through each line. You should have one answer per line. So no ifs, ands, or buts. Make sure that you're not actually subtly giving two responses with one answer. That will be overcoding. You will lose the marks. Again, no abbreviations. Look for any and all abbreviations, cross them out and spell it out over the top of it. Make sure you don't fall for that trap. Yes, it's clinicians marking these exams, and there is a little bit of leeway where they may decide to give you marks based off of an abbreviation, but the official line from the college about abbreviations is just don't do it. Finally, if you've done all those things and still have a bit of time free, just make sure you've got that diversity in your answers. Make sure you're not falling for the grouping trap, and that you're not actually giving the same answer just in slightly different ways multiple times. So if they are grouped, remember you only get the marks for the first response, and so make sure that you're having that diversity there to make sure you're catching as many answers as possible. Now, we've spent a fair bit of time on this bit of teaching tonight. I really wanted to get to this while we have that final opportunity to do it before, more practice questions before the exam. These are the things that should be fresh in your mind going into the exam, that you've got that plan of attack moving forward. Hopefully it's helped. Of course, though, you've also come here for questions. So let's get 2 minutes on the clock for our first case tonight. Your time starts now. All right, 2 minutes is up. Sorry about that little technical glitch. Not entirely sure what happened there. We'll see if that happens on the next one. Let's go through some answers, of course. So here we're looking for, in particular, what are the specific features that contribute to the diagnosis based on her presentation. So 3 clinical features is irregular periods, irregular menses, metabolic features, or specifically difficulty in weight control. I think you're probably safer putting difficulty in weight control, and of course hirsutism, that excessive hair growth. Now, of course, we do have other features that are diagnostic. That would be that subfertility or infertility, psychological symptoms like anxiety, depression. But remember, here in this situation, they've specified based on her presentation. So they want you to pull out those criteria from the information given here. And so, as people have put in already, fantastic. It's that irregular period, signs of hirsutism, difficulty controlling weight. Absolutely smashed it. Well done. And again, Demir, fantastic. Very good. Remember, in the actual exam, I'm going to pick on you. Make sure you're actually spelling out body mass index. I know it sounds stupid, but we're avoiding those abbreviations and making sure we're not missing out on any marks. Absolutely nailed it though, guys. Well done. And, of course, we've got more questions. Let's put another 2 minutes on the clock, and your time starts now. All right, time is up. Great to see some answers coming through. And this is one of the situations where we, again, have more correct answers than the number of answers requested. So always remember that they're usually playing the ball in your court, giving you that opportunity to pick up marks by having more things that are right than you need to have there. But this does give them the ability to then actually weight some of those answers to be more specific to the condition. So probably the best marks here are going to be, as most of you put up here, the A and B, so your serum free androgen index, which we would expect to be elevated. Likewise, we would expect to have an elevated luteinizing hormone, and we would also potentially check the follicle stimulating hormone as well in there to look at the LH-FSH ratio, which would be up. Now, those biochemical markers are going to be more sensitive and more specific towards polycystic ovarian syndrome. Of course, you would also be looking for random blood glucose to check for those metabolic disturbances and the pelvic ultrasound for those polycystic ovaries. Fancy that. Now, why would pelvic ultrasound be worth less marks in this setting than those biochemical markers? That's going to be because, don't forget, up to 70% of young women are potentially going to have polycystic ovaries on ultrasound. Likewise, it's not reliable for the diagnosis of it. So a lot of people with polycystic ovarian syndrome don't have polycystic ovaries. And so you're better off using some of those other criteria that are going to be that little bit more specific. It's the trouble when it's named after something that may not always be the case. Note here as well, of course, that the LH levels might depend on the phase of cycle. Yes, this is true. Levels will go up and down, but you would still expect overall them to be significantly more elevated than you would in someone without polycystic ovarian syndrome. And so if I had to put the bet between am I more likely to see elevated LH levels or cysts on ultrasound, I'd probably actually still go for the LH level. Hopefully that makes sense. All right. Now, other things that you would be considering in a case like this would be things like checking your thyroid's stimulating hormone. Again, we've got those changes to hair growth. It'd be something we'd be keeping in the back of our mind. You'd also be potentially looking at prolactin levels. The reason why they wouldn't be as applicable in this case here is that, again, the stem of the question here is what tests would be appropriate to confirm the diagnosis of PCOS. And so those other responses are going to be more excluding other conditions than they are confirming the PCOS, thus wouldn't get you the marks in this case. In clinical practice, you'd still be doing those tests, but be aware that these questions are going to really specify down what is the information they're trying to get, so tailor your answers to that. All right, of course we've got another question up here, so let's get 2 minutes on the clock and your time starts now. All right, time is up, and let's have a look at what the answers are. Now, there are new guidelines out for last year to go through the international evidence-based recommendations for managing patients and assessing them with polycystic ovarian syndrome. This is something that don't spend too much time reading before the exam, please. It's a big document, but it is something that I think for clinical practice would definitely be worth having a look at. Now, really happy to see some of those answers come through because you've absolutely nailed it there in terms of how important it is to make sure that there is a proper diet in place and trying to really maintain that healthy weight. So how do we do that? The standard things that you're going to be expected to put out there is going to be regular exercise, 30 minutes a day, at least 5 days per week. That can be expressed as sessional events, or in the guidelines there it also specifies weekly cumulative as well. So I think as long as you're acknowledging some form of exercise there, a physical activity with a regime that is sensible for that patient, you're going to get those full marks there. And again, being a priority, it's going to be weighted more points That's what I'm trying to say. Now, balanced and nutritious diet, but emphasizing a caloric restriction. You want to be on the lower end of caloric intake to manage that diet. And again, as long as you're acknowledging the diet there, you should get those marks. Probably grouped together would be referral to dietitian for meal plans, because essentially those two things are aiming to accomplish the same target. Specifying a healthy weight range to be aiming for is also important. This is a patient that's not dramatically outside those ranges, which is good. And so as long as they're under the 27 mark, you're going to be getting marks there. Of course, if you can bring that down to even 25, it'll be even better. But as long as you can get it, the evidence really is saying to try and get that under 27 shows the greatest metabolic improvements. Not necessarily applicable right now, but we also know that, again, keeping the BMI reduced also has massive implications in fertility, and that's also something that I'll be raising to this patient that down the line. That is something that we would also be talking about, given the obvious implications for PCOS and subfertility or infertility. Now, something that, truth be told, I wasn't actually aware of is the importance of getting proper sleep with PCOS. Patients that achieve at least 7 to 8 hours per night do markedly better in metabolic profile and regulation of cycle than patients that don't. So again, good marks there. And of course, acknowledging the psychological impact that this is going to have, so cognitive behavioural therapy or referral to psychologist for psychological support. And again, even if you specify cognitive behavioural therapy, I'd be adding into there that for psychological support to specify you're doing something, but why you're doing it. Of course, we are then also talking about symptom management, and so laser or electrolysis for hair removal for hirsutism management is definitely going to get you marks. So we've got the referral to a dietitian to help choose appropriate low-caloric diet. Fantastic. Regular moderate intensity exercise 5 times a week, 30 minutes per day. Absolutely beautiful. Referral to dietitian for Mediterranean diet. And yes, there's evidence for Mediterranean diet in this setting, and 30 minutes of moderate intensity exercise daily. Fantastic. Facial hair removal at salon. Yeah. I think it's fair that it may not be our area of expertise, but saying, hey, yeah, there's salons that can do that, I'd be giving you full marks if that was me. All right. Now, we have, of course, a second case up here tonight. I am only doing the 2 cases tonight just to try and give everyone a little bit of a break. I'm aware there's not much time left. I want you to be getting at least 7 to 8 hours sleep a night, and we did spend a bit of extra time doing the teaching at the start. But without further ado, case number 2. Let's get 2 minutes on the clock, and your time starts now. All right, time is up and let's have a look. And this is one of those times where they're going to be really picky on those fine little details. I can already see you've picked it up there in the chat. This is one of those things where we will look at that and we'll say, yep, cool, BCC, got it, beautiful, smashed it, done. It's a nodular basal cell carcinoma of the left cheek. So specify subtypes if you know what it is. You're going to get more of those marks, and specifying that location is going to get you more marks as well. It seems over the top, I know, but it's showing that specificity of what you're after. So a very big congratulations, and of course a gold star goes to Mia for this one. Absolutely smashed it out of the park. Well done. And of course, we've also got here, oops, I missed again because you put, is it going to come up there? Basal cell carcinoma. Now, here's the thing, and look at this here, you're still going to get a mark. You're not going to be missing out on too much there. You're going to get that thing, that the assessor is going to look at that and say, yeah, okay, you're someone that knows what you're doing, that's okay. But you're throwing away marks. So do be a little over the top and specify those sides, just for those extra marks there. It's pedantic, I know. And this is, again, why I think so many people struggle with this exam, because it's little traps like this that are going to catch you out. Now, I want to point out again, if you do put BCC, you're going to miss out on all marks altogether because of that official line of no abbreviations. And so this is one of those reasons, again, why I say at the end of the exam, try and have a quick read through and see if you've fallen for one of these traps here. Make sure you're really spelling it out. All right, hopefully you're not too cranky with that. Now, of course, one of the things here that let us know this is a BCC, one the most common type of facial skin cancer, but we've got that classic kind of shiny, slightly pearly kind of nodular, smooth surface there. You can see a couple of blood vessels kind of creeping across, and you've got that central ulceration, just absolutely classic for it. Now, as you can see, this image came from DermNet. What are the odds of that? Really do become familiar with the ones from DermNet because you'll see them time and time again. The other thing I wanted to point out here, if you look carefully at this photo, that doesn't look like a cheek. Looks more like just a spot kind of below the eyebrow there. This is where you have to sometimes suspend disbelief, because sometimes they might not actually have a photo of a BCC on a cheek to show you, but they found this other one that has those classic appearances. They try to make things match up as much as possible. I don't know why the questions don't sometimes just get rewritten to express exactly what's in the photo, but if you do see little things like that, just keep in the back of your head that could just be the best photo of the rash or skin condition or whatever it is that they could find. Something to bear in mind. Now, they do have here, still can't understand why the college wants us to differentiate BCC from SCC, as management is essentially identical. Yes and no. I mean, they each have slightly different potentials for transformation and spread, and so yes, we're going to manage them the same way, essentially by excision. Margins are going to be, pretty much the same for these kinds of lesions there. But from that risk factor for progression, I think it probably is worthwhile being able to say, good spot, oh, bad spot, slightly less bad spot, if that makes sense. Clinically, of course, it probably doesn't matter that much if you're still planning on taking that lesion out. You'll get the histology report back and you'll be able to make more sensible, informed decisions based on that report. This is more that, I think, reflection. They want us to show that we have that consultant level, that fellowship level knowledge base to be able to differentiate these kinds of skin conditions. Hopefully that makes sense. Of course, we have another question lined up. Let's get 2 minutes on the clock and your time starts now. All right, time is up, and let's get to the answers here. Now, this is one of those things that has come up in exam reports. It's come up in practice exams. I'm sure it's come up in actual exams time and time again. We are the sunburnt country. A lot of what we do is skin cancer related, at least at the practice I'm in. For those that aren't aware, I'm in Mildura, which is located approximately 3 kilometres south of the sun. And so I spend a lot of time dealing with this kind of stuff. What are the things you're going to be asking here? And these are things that are going to be additional history to what's already provided. So that family history of melanoma in a first degree relative, if you just specify family history of melanoma, you'll probably get 1 mark, but it is the first degree relative that places them at a significantly increased risk to get you the 2 marks there. A personal history of non-melanocytic skin cancers is also a significant risk factor, 2 marks. History of tending to burn in the past is also a mark. Significant ultraviolet exposure with burning during childhood. There is a little bit of caution there. The with burning may be considered overcoding. And so you could just leave it at significant ultraviolet exposure during childhood. I think you would probably be okay, though, in this instance, using that with. Now, if you were to try and ask about fair skin type or Fitzpatrick skin type or eye colour, those are probably veering more into examination findings. And so I don't think in this instance where you've been asked for aspects of history, I don't think you would actually get the marks there. And so, again, we've got some things here as did you get sunburnt as a child? That's a fantastic way of phrasing that point from earlier. I think you get 4 marks for that one. Personal history of skin cancers, brilliant. Number of dysplastic nevi diagnosed in the past. Now, the dysplastic nevi, the number is certainly a risk factor for skin cancer development. In this instance, yes, I think you would get marks, but it's a potentially risky answer in that, similar to asking about skin type, Fitzpatrick skin type or eye colour, it kind of veers a little bit into that examination aspect. I think, though, if you're saying, have you been told you've got lots of moles or spots on your body or dysplastic nevi, yeah, you'd probably get it. And so I think if you're struggling to think of other things, go for it. There's probably other answers there that are perhaps a little bit safer. And as you got here, he's surprised with diagnosis. So could you say personal history of skin cancer? Definitely yes, because I have seen this in my own practice, of course. Where patients come in, they say, "Oh no, that's just a spot. That's fine. That's nothing." And you say, "Oh no, that's a giant BCC. We need to take that off." You've had multiple BCCs, SCCs. You've had a couple of melanomas. That's not a good one. Oh, you're sure? Sometimes we need to save patients from themselves, and so definitely still fair game. Hopefully that makes sense. Maybe I just live in a place where everyone's got skin cancer. Again, I live very close to the sun. It's very hot. You can see a lovely sheen on my head where I think 30-something degrees tonight. It's the best place I've ever lived. Absolutely love it. Now, of course, we've got another question. So let's load up 2 minutes on the clock, and your time starts now. All right, so let's get to the answers here. These kinds of questions where they're asking about consenting for a procedure, they're really wanting you to spell out what's involved in the procedure here. Of course, they go that next step and say, please provide the five, it's more than five, but 5 steps of performing an excisional biopsy. Doses are not required. And they want to make sure that this is something that I think most GPs would do as a bit of bread and butter. You may not be surgically orientated, and that's fine, but this is something that commonly occurs in general practice. You should have a very good grasp of what's involved for it, and even if you don't do it personally, you're about to refer them on to someone else that does do it. And so a part of that is getting that consent and being able to explain to them, this is why I'm referring, this is what's going to happen. Now, of course, we're going to clean the skin with a isopropyl alcohol or chlorhexidine or povidone-iodine-based solution. As long as you're putting one of those things in there to reflect an appropriate skin wash, you're going to get a mark. Marking boundaries with a surgical marker containing a 2 to 3 mil margin of normal skin. Really, I think it depends which guidelines. This is an eternal battle between is it 2 millimeters or 3 millimeters. As long as you're putting one or the other, for cases like this, I think you're going to get the full marks there. As long as you're not putting 1 millimeter or 10 millimeters, they're going to see you're pretty sensible. Infiltrate the field with lignocaine or an appropriate anaesthetic. If you specify lignocaine with adrenaline, fantastic. Excise the lesion using a blade or scalpel to the level of subcutaneous fat. And really, for a true proper histological diagnosis of a suspected malignancy, you should be making sure you're getting to that subcutaneous fat layer. Close the wound with sutures. Apply appropriate dressing, some form of skin protection, and of course, discuss wound aftercare. If you get stuck for these questions, and it's easy to do in the stress of the day, really spell it out, break it down to basic steps. Anything that's involved in doing one of these procedures, you're going to get a mark for. If you can specify it out into one step, you are going to have more things that you do than things that they're requesting. And so you might not even get to excise the lesion. They're probably going to weight marks towards that being worth more. And admittedly, in here where I've got the excised lesion, you could have even specified the margins there. I think you can get marks for that. Let's have a look through some of the answers here. So cleaning with chlorhexidine to prepare sterile field, beautiful. Inject lidocaine with adrenaline, fantastic. Mark area of excision with 5 millimeter margin. Particularly on faces, I probably wouldn't use a 5 millimeter margin. I'd probably stick to, personally, I'd probably do a 3 millimeter margin for this. Perform excision biopsy to send for histopathology. Fantastic. That is gold. You're getting gold stars here, and that's something that I need to add to this marking rubric as well. Specifying that you're actually sending it off for histopathology, crucially important, and is definitely going to be getting you multiple marks for specifying that. And again, it's specifying why you're sending it. You're sending it for histopathology, vitally important. And of course, closed surgical wound, brilliant. Skin wash with betadine, draw excision borders, beautiful. Infiltrate with 1% lignocaine with adrenaline, 5 mil subcutaneously. Don't get too caught up in dosing. They have specified, pardon me, dosing not required. So I'd probably leave the 5 mil out. Excise the lips to subdermal fat layer, beautiful, and suture with 4 millimeter Vicryl. Yep, perfect. You could do Vicryl here, that'll be fine as well. You have said, oh shoot, not Vicryl. Different people would use Vicryl. Use what you got, use what you're comfortable with. As long as you're specifying, some good form of suture, I think you're going to get marks there. Even just saying close wound with sutures is probably adequate enough. All right. Now, I did say we were only going to do 2 cases tonight, so well done for getting through both of them. And we're still hitting that 1 hour mark. I didn't want to make it too late. I want to make sure you get your sleep as well. But I do want to acknowledge the fact that you're on the final lap of the race. This is the home stretch now. There isn't too much longer to go. I'm aware not everyone's going to be sitting the exam in a couple of days' time, but I also wanted to give you a chance to shoot out any last-minute questions or things that you wanted to just vent or get out there before the exam itself. So again, this may be your last opportunity to get some of these things out. Please feel free to throw anything out in the chat now. I know that one of the things I do want to specify is try and get a bit of a break, get some rest before the exam. One of the things I like to tell people is the day before the exam, you're not going to take anything in. Don't beat yourself up. If anything, at maximum, do a half day of study. Otherwise, feel like taking the whole day off, take the whole day off. Give yourself the chance to recharge your batteries, physical and emotional, so that when you get into that exam room, you are prepared for it. I don't want you walking into that room feeling burnt out. You're probably going to leave the room feeling burnt out, so give yourself the best chance possible when you come into there to actually be ready for that exam. Make sure you've got that plan of attack. Make sure that you are allocating time to do different things. Another tip I've given before, when you do go in, one of the first things I think can be helpful is to actually read through the exam, know what you're getting yourself into, know what the questions are, make notes, make use of your scratch paper that you've got there, and plan out how you want to tackle the exam. What kind of rough order do you want to do these questions in? And try and do the easy ones first. There's multiple reasons for that. One, it builds your confidence. It lets you know, I've got this. You're also more likely to be more time efficient by knocking off those easier questions early, the ones that you're not going to struggle or spend more time thinking about. And of course, finally, the thing with doing it that way is that often you'll actually prompt yourself for answers down the line for other questions that you may not have come up with otherwise. There might be components of that history, components of the question or your responses that jog your memory about something that otherwise you could have missed. Hopefully that makes sense. Now, I'm not seeing any questions coming through, so hopefully that means everyone's doing well, everyone feels happy, everyone feels confident. I think the fact that you're here tonight shows that you care, you're studying, you're putting in the work, and I'm sure that's going to reflect on the day. Of course, make sure you read the question being asked. Make sure that your answers are specific and concise, no ifs, ands or buts, no commas, no apostrophes. Try to make sure you don't overcode. One answer per line, to the point where it's often really helpful when they say give 5 answers, write 1, 2, 3, 4, 5, and only 1 point goes after each number. Diversify your answers so that you don't fall for any grouping catches, grouping problems, and of course, no abbreviations. No abbreviations. Read through, cross them out, write the thing out in full. If you don't know how to spell something, that's okay. As long as it's vaguely interpretable as to what you're trying to specify there, you're going to get the marks for it. They do say, for some reason, they don't accept abbreviations, but they don't give a crap about spelling, which for me was wonderful to see. Someone who relies quite heavily on spell check. Very, very helpful. Of course, that's probably enough. You've probably heard me waffle on enough for yet another Wednesday night. Go forth, get some sleep. For those of you that are sitting the exams this weekend, best of luck. I think you're going to be absolutely brilliant, and just surviving the exam is worth a pat in the back, no matter how you feel walking out. Everyone feels a bit defeated when you do walk out. Wait for the results to come through and have a bit of a break between sitting the exam and the results. If you're not sitting the exam, I'm going to do one other final little live stream, just a brief one next week, just to touch base and see how everyone's going. It'll be more informal, just catching up, and there'll be a little bit of a break before I resume doing these sessions again, 12 weeks before the next KFP exam, 2024.2. So to everyone who has joined me for the last 11 weeks, 12 weeks of doing these sessions, thank you so much for your time. Your time is the most valuable thing you can give me, and I cannot say how much I appreciate it. I will see you all at the next live stream. Till then, of course, take care, guys.